I would like to thank the DISCO team and Professor Philippa for this opportunity to present the DISCO Kids results in this meeting. So DISCO Kids in full is dialogue intervention to support communication and openness in children. So about 2.1 million children below the age of 15 years are living with HIV, and over 90% of these live in sub-Saharan Africa. And increasingly, most of them are growing and reaching adolescence. And disclosure of HIV serostatus to infected children is a growing challenge for caretakers and health providers. Disclosing to a child about their HIV diagnosis is important in comprehensive HIV medical care, and studies have shown, as Professor had earlier indicated, that the children have better treatment adherence, mental health, behavioral and clinical outcomes, including retention in care and improved family relationships. Despite these benefits of disclosure, caretakers commonly delay to disclose. And WHO recommendation for HIV disclosure in children is from the age of 6 to 12 years, and the Uganda guidelines states that children should be disclosed to from 8 to 12 years. However, it's not clear how disclosure should be done in the guidelines. So the study was set to assess the effectiveness of a caretaker and child-focused cognitive behavioral intervention that is culturally appropriate, potentially feasible to scale up within the context of HIV care and treatment in sub-Saharan Africa. To assess if this cognitive behavioral intervention is appropriate and responsive to the needs of caretakers and children in the specific context of HIV disclosure. So the study had two arms. The control was standard of care. So again, programs have different ways of doing or supporting caretakers and children in terms of disclosure. And so the intervention was answering how do we disclose to these children. So the intervention was basically a problem-focused cognitive behavioral intervention to increase caregiver disclosure to HIV children of their HIV status. Design was a clinic stratified randomized controlled trial that was done in 6 clinics in Kampala, and the children had to be 7 to 12 years old and unaware of their HIV status by the caregiver report. The caregiver had to be 18 years and above in age, and they had to be the primary caregiver. So we collected data, qualitative data, semi-structured interviews. We collected dried blood spots for viral load testing, hair samples for drug level measurement at baseline, 6 months, 12, 18, and 24 months. And the primary outcome was full and accurate disclosure of the child's HIV status by the child's caretaker or counselor with caregiver's permission. Secondary outcomes were child ART adherence, viral load, caregiver and mental health, social role and functioning of the child, and caregiver-child emotional closeness. So the intervention had counselor-led group sessions, each 3 hours, and there were 3 sessions over a period of 6 weeks. And basically, they were about understanding child development, age-appropriate communication, because this can be a challenge, HIV and AIDS, ART basics, and then developmental approach to disclosure, identifying barriers and ways of overcoming them, talking to children about difficult topics, and not just HIV, and then the guidelines for appropriate disclosure. In addition, there were monthly dyad sessions, dyad meaning a caretaker and a child, and these were 3 as well, each lasting 1 hour, and they were led by a counselor, and they were child-centered. And then we had booster group sessions and dyad sessions at the 6 months time point. In addition, at 6 months, there was at 6 months, there was a video that would basically highlight the challenges to disclosure and benefits, and this video is based on different studies that have been done in sub-Saharan Africa as part of the intervention. So that's one of the activities that will just help the caretakers to share their differences. And more in detail about the intervention, there were participatory activities, role plays, storytelling and reflection, relaxation and mindfulness activities, including homework for the caretakers and also for their children. So I'll just mention that it's a famous river, highlighting that in a child there's a river, it's flowing, and most times the river will find stones and hindrances in life, but it's going to keep flowing. It will just go around the stone, and so it was brought out as a fact that these children have this hindrance, but otherwise there's a life in them, and they have got to live over this hindrance and be able to achieve their desired destinies. So at baseline, there were 300 dyads, children aged 7 to 12 years that were enrolled, and by the end of the follow-up period, there were 287 dyads. This is about 96% retention, and those were the respective clinics. So caregiver participant characteristics were more or less similar in both groups. The median age was 36 years, most were female and mothers, and most were primary caregivers, and about 85% of them were HIV positive. The child participant characteristics were also similar between the two groups, median age being 9, most were, about 50% were female, over 97% were enrolled in school, and about 90% were on triple ARVs. So primary outcome, pediatric HIV disclosure, we had 85% of those that were in the intervention disclosed, and the unadjusted odds ratio showed that the intervention group had 23 times higher odds of disclosing the HIV status to the child compared to the control group. So overall, this intervention increased courage to talk to the child about her HIV diagnosis. The caretakers were empowered to communicate more openly with their children, and not just about HIV, but about other difficult topics. They felt more knowledgeable about their children's needs as they grow up and how best to support them, and they were better able to cope with their own feelings of stress. So in conclusion, this intervention was highly acceptable. It improved child caretaker communication, was effective in respect to pediatric HIV disclosure by 6 months of follow-up, and the older the child was, with greater caretaker disclosure self-efficacy, were independently associated with pediatric disclosure by 6 months. So in terms of research utilization, this is a research that needs to be incorporated into policy and guidelines, and then also the programs. So we needed to map our audience in terms of who to give the results. First were all the participants. We needed to avail this intervention to the controls, and then the staffs at the clinics where the study was done, because they are potential champions to this work. The key personnel in pediatric HIV care, because they will use the intervention ultimately in the pediatric HIV programs, including adolescents who may also have challenges with disclosure. And we felt we should disseminate these results to PEPFAR Uganda AIDS control program as the possible supporters and funders for this intervention to move on. And then we would like to also present the results to the National Pediatric HIV Subcommittee. So, in terms of knowledge translation, this study feeds into the process and the materials. And the results dissemination was done to all participants, study staffs, HIV positive adolescents and youth in the control group. And all of interest, this time during the dissemination, we had about 15 groups of 10 caretakers, and they had 3 sessions per group for 3 hours each. And this time they were done during the weekend. So in terms of implementation, this would be an important area to explore. And we also had a stakeholders meeting. So the caretakers appreciated the intervention and highlighted that it went beyond just helping them to disclose HIV status to the children. It generally improved their communication to the children. And the controls also appreciated the process of being taken through the intervention. The staff requested for training of other staff at HIV clinics and scale up of this intervention. The youth and adolescents requested for long-term support after disclosure, and also for an intervention that would aid them disclose to potential marriage partners. Stakeholders really emphasized that we needed more analysis of the study results, especially regarding the ART treatment outcomes, adherence, virus suppression, etc. Those are the risk references, and that's the DISCO team. And I would like to acknowledge the principal investigators, Professor Philippa Musoke as the Ugandan PI, and Dr. Lisa Butler, as earlier indicated, was the other PI. And also co-investigator was Dr. Monica Etima, and this study was funded by USAID, PEPFAR, SOA, and the US National Institutes of Child Health and Development. Thank you.